I would like to introduce Professor Laurent Pierrot from France, France. He is one of professors from all the world, not only in Vietnam, but all the world. He is very well known in interventional neuroradiology. He come to Vietnam and hand us for more than 20 years now, 22, 3 years now, just now. And many times, we cannot count how many times he come to Vietnam. We don't know because there are too many. So he present the topic instant study, version illustrations of intracranial aneurysm coiling, Optima coil. Professor Laurent Pierrot, please.
Thank you, Professor Pham Minh Tong. It's always a pleasure to come in Vietnam and to meet you and the Vietnamese physicians. So I will have the chance to present instant study, which is a recent evaluation of intracranial aneurysm coiling. The treatment was done with Optima coils, which is a coils from BALT. I think it's always important to evaluate again our treatment, and we will see that we have very interesting results in this prospective series. It's not working. I have my presentation of a key. You need it? I have my presentation of a key. Okay, okay, that's okay. Okay, thank you. So here is a design of instant study. So I am the PI. You see who were the members of the CEC, Professor Herbreteau in France and Dr. Anne-Christine Januel in France also. It's an international, non-interventional prospective multicenter study. So the primary objective was to evaluate the mortality related to the Optima coil system at 30 days after the procedure. And there were a lot of secondary objectives, mortality at 12 months, occlusion rates at 12 months, technical features of Optima coils. The goal was to include the 300 patients, and finally we had 18 investigational sites in 5 countries: France, Italy, Latvia, Spain, and Switzerland. And the follow-up was evaluated at the discharge from the hospital and at 1 and 12 months. So the design inclusion criteria we were including in instant small and large intracranial aneurysm, ruptured or unruptured, and also recanalized aneurysm. Recanalized aneurysm are analyzed in the same group than unruptured aneurysm. Intended to be selectively treated with the Optima coil system, balloon and stent-assisted coiling was allowed. Only one aneurysm treated during the procedure. It's always a big mess when you have a patient with multiple aneurysm for the statistical evaluation. So the reason why we were deciding to have only one aneurysm treated during the same procedure. Indeed, we need informed consent. What was excluded is a giant aneurysm greater than 25 millimeter. Also, recanalized aneurysm initially treated with stent or flow diverter we are not included, as well as aneurysm treated with parent artery occlusion. Dissecting or fusiform aneurysm were excluded. And finally, his aneurysm was intended to be treated as a stage procedure. They were excluded. So it is status on timelines of the study. You see that the first enrollment took place in April 2019. The last enrollment in September 2020. The end of the follow-up was obtained in April 2022, and the final clinical report will be for May 2023. So you see the number of patients included per country. The greater number of patients were included in France, and you see the inclusion in according to the centers participating to the study. So we were enrolling 300 patients, but in fact there were five ineligible patients due to the absence of consent in 4 cases, and one patient was non-compliant for the follow-up. Also, 2 patients were included because they were not treated with Optima coils. And finally, the treated set was 294 patients with 161 patients with unruptured aneurysm or recanalized and 133 patients with ruptured aneurysm. Regarding the follow-up, 287 patients completed the 30-day visit and 270 patients completed the 12 months visit. So here are the characteristic of the patients and the aneurysm. So you see the age was, in the global population, the mean age was 56, which is quite classical. As usual, there were more women, 63%. There was a medical history of hypertension in 40% of cases, and they were active smoker in also 40% of cases. Most of the patients were low grade. You see, for unruptured aneurysm, most of them were grade 0 or MRS 0 or MRS 1. Regarding ruptured aneurysm, they were also mostly low grade, grade 1 or grade 2. Now, when we look at location, the most frequent location for ruptured aneurysm was ECOM aneurysm, followed by ICA aneurysm, followed by MCA aneurysm. The distribution is different for unruptured aneurysm. You see that we have 3 important groups for unruptured. First ECOM, but just behind ICA, and finally MCA. Regarding the size, most aneurysm were small, 90% of cases. When I say small, it's less than 10. Neck size was the mean neck size was 3.5 millimeter in the whole group. And you see that large neck aneurysm with a neck greater or equal to 4, we are 44% for unruptured aneurysm and 25% for ruptured aneurysm. Now, some technical information regarding the use of Optima coil system. You see that the mean number of coils implanted in both unruptured and ruptured aneurysm was 5.6. It's interesting because we were calculating this mean number several years ago, and at that time, but when I say several years ago, it was 15 or 20 years ago, and at that time the mean number of coils was 4. So you see that we increase the number of coils we are able to place in the aneurysm sac, probably because we have a lot of coils now available with different shape, different size. So probably the reason why we are using more coils to treat one aneurysm. The most patients were treated only with Optima coils. You see that there was a lot of balloon-assisted coiling. 47% of balloon-assisted coiling or remodeling in ruptured aneurysm, a little bit less in unruptured aneurysm, 27% of balloon-assisted coiling. You know, I think singularly in France, a lot of teams are using a balloon, even if it's not to protect the neck, because the neck is not always large, but sometimes they use a balloon just in case of aneurysm rupture to protect the aneurysm if the aneurysm is ruptured. You see that stent-assisted coiling was very limited used in ruptured aneurysm, 3%, but was very often used in unruptured aneurysm, 34% of aneurysm. So now when we look the global results of the series, you see that the mortality related to Optima coils and procedure were 0%, which is very interesting. And the mortality rate related to aneurysm rupture was 0% in unruptured aneurysm and 3% in ruptured aneurysm. There were 4 deaths in the group of ruptured aneurysm due to subarachnoid hemorrhage in one case, to hydrocephalus in 2 cases, and to vasospasm in 1 case. Now, when we look at morbidity rate, there was an overall morbidity rate of 1.2% in the unruptured group and 21% in ruptured group, but the morbidity in the ruptured group was mostly related to subarachnoid hemorrhage. So when we look now at thromboembolic complication, you see that we have 5.6% of thromboembolic complication in the group of unruptured aneurysm and 7.5% in ruptured aneurysm. Most complications were during the procedure, so 2.5% in unruptured group, 4.5% in ruptured group, but you see that the clinical outcome of this clinical complication is better than expected. You see that in the group of unruptured aneurysm, all thromboembolic complications were not associated with clinical worsening below MRS2, and in the group of ruptured aneurysm, you see that 83% has not clinical worsening below 2, so which means that finally we are now able to manage properly most of the thromboembolic complication. We have a relatively high percentage of delayed thromboembolic complication, post-procedure thromboembolic complication. You see 3.1% in unruptured aneurysms, 3.8% in ruptured groups, and you see again that the clinical outcome is good, not in an unruptured group, but not in ruptured group. You see that in a ruptured group, when you have a delayed complication, delayed thromboembolic complication, in 40% of this group, you will have clinical worsening with MRS 3 to 5. So probably because there is a delay in the treatment. When you have a thromboembolic complication during the procedure, you will treat it directly. But when you have a delayed complication, sometimes, the time that the patient comes to the hospital will preclude to do any treatment due to the delay. So that's probably the reason why we have a worse clinical outcome in case of delayed thromboembolic complication. Now, when we look at the hemorrhagic complication, we had 2 patients with pre-procedural hemorrhagic complication. One patient had a rupture during the preoperative DSA before coiling, and another had intraventricular rebleeding related to DVA placement of the ventricular shunt, and you see that both of them were occurring in the ruptured group and were associated with clinical worsening with MRS 3 to 5. There were relatively few intraoperative rupture, 2.4%, a little bit more in ruptured groups, 3.8% compared to 1.2% in the unruptured group. What is interesting to see is that, we were using the balloon to try to protect the patient in case of intraoperative rupture, and it probably explains why the clinical outcome is not so bad. After intraoperative rupture in this series, we have no deaths. We have clinical worsening only in the ruptured group in 40% of intraoperative rupture. So it means that the use of the balloon during the procedure for ruptured aneurysm at least is very useful, singularly in case of intraoperative rupture. You inflate the balloon, so you stop the bleeding immediately, and you can continue to coil the aneurysm to protect the patient of a further bleeding. Finally, there were also post-procedural hemorrhagic complication, not in the unruptured group, but in the ruptured group in 1.5% of cases, but there was no clinical worsening in both cases. Now, complication due to SAH over the course of the study, so only in the ruptured group, you see that vasospasm was depicted in 26% of cases, on hydrocephalus in 13% of cases. What is a little bit surprising in this series is that, the clinical outcome of hydrocephalus is relatively worse, is relatively bad. You see that we have 28% of deaths, which is not nothing. And we have 5.6% of clinical worsening with MRS 3 to 5. On the contrary, you see that vasospasm is not associated with a very high mortality, 5.7% on clinical worsening, MRS 3 to 5 in 5.7%. I have to accept that I was thinking until this study that it was a little bit the contrary, that hydrocephalus was less associated with death than vasospasm, but you see that at least in this series is not true. So as of now, we don't have the analysis of the anatomical result. We will have them in very few weeks, I think. So I will present them in the next Congress in Vietnam. You know that evaluation of anatomical result is always complicated in studies because you have to collect images to have a double reading, blah, 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 blah. So the reason why we don't have the result as of now. So finally, what you see is that these results are showing us that probably we have improved the treatment along the time, not only due to the new coils, but also due to the new devices we have, new microcatheter, new guide wire, blah, 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 and also probably due to the improvement of our skills. So you see that, for example, if we compare the results of instant to Athena, okay, Athena is a relatively old study. The recruitment took place between June 2005 and October 2006, but you see that in this series, which was conducted in more or less the same centers, the overall morbidity was 1.7%, more or less comparable to what we have in instant, 1.2%, but there was, in Athena, there was a mortality. Athena was dedicated to an unruptured aneurysm. You see that there was a mortality of 1.4%, and now we are with a mortality of 0%. Now, when we look at the group of ruptured aneurysm, you see that in instant there is no treatment-related mortality and morbidity, and in clarity, which was conducted also in the past, between November 2006 and July 2007, treatment-related morbidity was 3.7%, and treatment-related mortality was 1.5%. So clearly, from this study, it seems that there is an improvement of the safety of the treatment with standard coiling, probably due to improvement of the devices and improvement of our skills. Thank you for your attention.